Um, Good morning and good evening to everyone. My name is Kate and I'm one of the co-leads for the Palliative Care Sustainability Network and on the development group and the assessment group for the Greener Palliative Care Awards. And this is one of our education sharing practice sessions that we are having regularly to allow our pilot sites, but also everyone else, to share in what we're learning as we go along this process. One of the questions that has come up quite a few times is around life cycle analysis, which is why we're welcoming Dr. McGain today. He's going to talk us through his expertise in that area. But just before we get started, I've got two things I just wanted to share about the awards in general. If my slides will change. Yeah. The first is to say that we've got some exciting announcements coming in the new year. So as most of you will be aware, what we've been doing for the last just under 12 months is running a pilot program, which we started with 10 sites. And we have been discussing in our development group what we do after that pilot site, after that pilot scheme ends. And we should have our first awards awarded in March of next year at the Palliative Care Congress, and we'll have an online celebration event to celebrate that as well. But in the new year, we will start revealing what will happen after that, which is going to be very exciting. So please look out for updates on the network page and on the email list. And if you're not on either of those and would like to be, just pop a question in the chat and I will tell you how to do that. And then I just wanted to offer a little update on what we ask of you in terms of life cycle analysis before we all start hearing from Dr. McGain and start slightly panic, because it's going to sound very impressive, I think. And that is, as part of the pilot, we've been reviewing what we ask our sites to do, and we've just had a small change of language, particularly around the bronze award. So some of you might recognise this is what we ask for in the bronze level. This is silver and gold. And I think the wording for the bronze level suggested that we wanted you to undertake a sort of publication level life cycle analysis on a clinical product. So we have changed the wording to say that for bronze, we're asking you to demonstrate understanding of the basic principles. So I just wanted to point that out before we start. I will now stop sharing. So as Dr. McGain says, we can see each other's faces, which is much nicer. So feel free if you can and you would like to, I need to do it, to turn your camera on. You can just say hi. Good morning.
Excellent.
Brilliant. Lovely. And I will let Dr. McGain introduce himself, but we are welcoming him from Australia, which is why we've gone for 8 o'clock on a Monday morning. I know there's never a good time. I'm not sure 8 o'clock on a Monday morning is a great time, but thank you for those who've made the time. And that's why I'm recording it, so we can share it with everyone else. Dr. McGain, over to you.
Yeah, I have a canine friend who's demanding Merry Christmas all. Just before we go any further, just for those just fairly recent, I suppose. Where is it? Okay, so you might be aware of this. Have a look, check it out. It's only a static website at the moment, as it says coming soon. So this is a collaboration between us at the University of Melbourne, but also the National University of Singapore and quite a few others who are engaging with trying to do more systematically the sort of things that we're going to discuss now. Okay, so lots of exciting things happening in the field. So let me just get my slideshow up. And this will be, I suppose, more of an example of what, because I always find it useful personally myself to go through study. This was one of ours that we did. Can you all see that, Kate?
Yep, we can see that.
Yeah. Some of the sections I'm going to whip through quickly, but others not so much. And we're going to choose knee replacements, not because I dislike orthopedic surgeons, but because it is a big carbon footprint and they use lots of things as well as anaesthetists. So, yeah, I'm based in Melbourne. I'm director of intensive care actually at one of the hospitals in Melbourne, Footscray, and I work in anaesthesia at Western Health as well. So my role at the university is in this sort of field of sustainability. These are grants that I've received from colleges of anaesthetists and anaesthetics, intensive care, as well as the National Health and Medical Research Council. I'm a member of Doctors Environment. In fact, I have to disappear well and truly on the dot to a meeting this evening for that, and thank many people the Western Health and the University of Melbourne. So we all know that surgery is a high carbon footprint part of the world, and it's about the waste extravaganza. Everything you see in this picture, except for the metalware and perhaps the surgeons, is reusable. Everything else is single-use chuck away, including the ligature, which costs between $500 and $1,000. So, £250 to £500. And it doesn't have to be this way. This is at Western Health where I work. We've got reusable gowns, reusable drapes, reusable plasticware, for example. So that's a sort of a bit of a lighthouse, as we describe it. And it's very important to have a lighthouse because otherwise you're in a sea of darkness, and other junior doctors who come through, rotate through, the fields of surgery, anaesthesia, intensive care, get to see this as reality rather than something that existed before man landed on the moon. So it's exciting to be able to show what can happen, as well as studying, well, what is the footprint of reusable versus disposable? Is it actually better? What's the water use? So on and so forth. So we're going to talk about knee replacements. The main study, this was like all, I suppose, in-depth LCAs, life cycle assessments, they take a lot of pain and suffering. But I suppose it's the same for any sort of research. And this one was in particular involvement of Lou A, who's an engineering professor at the University of Melbourne, and Scott McAllister, who's my, in a sense, right-hand man, who's the life cycle assessment expert, along with the rest of the clinical team. So, like you could sort of think, what was the approximate carbon footprint of operation? And it might be interesting to, as we go along, does anyone have some ideas of what that might be and what it all means? Before I go any further, 1 kilogram of CO2, which is a rather nondescript number in a way that never really made sense to me, is so, putting it in terms of, say, petrol, so that 1 litre of petrol is about just over 2 kilograms of CO2, similar to diesel. In the UK, 1 kilowatt hour of electricity, an average UK household I was looking at was around 15 kilowatt hours per day. So the actual footprint in the UK is something like, because you have a lower, you have an energy mix that's got more renewables, a lot of wind in it, then that's around about 5 to 6 kilograms of CO2. So it's like burning a couple of litres of petrol again. So it's interesting to think about Kate, would you like to hazard? Because I don't know anyone else. Do you have any ideas about what the footprint might be for an operation? Anyone?
I want to go quite high, like a ton. Like it's huge.
Okay, that's exciting. You want to go high? We're going to bid you higher or lower. Okay, you're going to say ton. Anyone else want to give a number? I'm not going to influence anyone, but we'll hold that as 1,000 kilograms for the moment. We'll keep going. There is quite a bit of variation according to the type of operation, of course. You imagine cardiac bypass versus, a carpal tunnel resection. And then I suppose the other question is, when you break it down, what proportion would be coming from the actual surgery, the anaesthesia, and then the heating, ventilation, air conditioning, and all the rest of the things going on with engineering, which we thought was an important part as well. So we'll talk about a ton later. So all those sorts of things we know, joint replacements are common. Interestingly, Chantal Rizan, who's now based in Singapore, but was based in Brighton, knee replacement 85 kilograms per operation. Sorry, Kate. And excluded anaesthesia and heating, ventilation, air conditioning. And that was probably, her numbers were lower for a laparoscopic cholecystectomy. Another one showed about 190 from France. Didn't include anaesthesia or linens, for example. So there's some variability there. So we thought, importantly, France, as you know, essentially is based on nuclear for their electricity. But the problem is most hospitals in Europe, for heating, which is a much more important part of your energy mix than it is, say, in Australia, most of that heating is done by gas still. That's why you're in trouble because of that war in Ukraine, Russian gas. So it was interesting talking to a Dutch compatriot recently where they said, oh yeah, we've increased our coal use. I said, what do you mean you've increased? He said, well, we just don't have as much gas. It's too expensive to burn the gas from Russia. And we can't get enough of it. So we're burning more coal. Fascinating, the land of wind. So there's all these sort of flow-on effects you can see that are happening. And that's why I find it really fascinating to compare and contrast. So local information is very important. So anyway, getting back to our background, there's some studies, the importance of anaesthesia perhaps. A good colleague of mine from Vancouver, Andrew McNeil, who's a gastroenterological cancer surgeon. And that related to the naughty anaesthetist using desflurane, which is much less frequent. In fact, basically doesn't exist in the UK, as you might be aware now, because of its high greenhouse gas potential. So that once that goes out of the story, then anaesthetics probably becomes much less important. So we wanted to look at what is the total amounts, what's surgery, anaesthesia, engineering. We looked at 10 elective routine knee replacements in our hospital in Melbourne. We only looked at the operating theatre, so it's important to always define your goal and scope. You could be looking at the rooms afterwards, and as well as the recovery room, what goes on in the wards, what goes on beyond the wards in rehab, for example. But we just focused on the actual room of the operating room. So we excluded staff and patients' travel, which we realise is important. But one of the reasons why we did that, you'll find more and more studies are including that, is that the reality is that you can't get away with not doing the operation in an operating theatre. It's different to something like dialysis, where home dialysis versus in-centre, either peritoneal, but more closely, I suppose, is hemodialysis. That becomes really important for comparing and contrasting hemodialysis at home versus hemodialysis in centre. So not so critical for something like an operation where everyone jolly well needs to turn up. What makes a difference, of course, is how people get into the hospital, and that is another important area as we electrify our world. So, Kate, just interrupt me. Is this going too quickly? I need a bit of a cadence check.
Not for me. And I can see someone else saying nope. So I think you're okay.
Okay. Because I'm looking at the full screen, so I'm not seeing people. But please interrupt if people say, and if someone puts a hand up, can you just let me know? Because I think it's fine to interject. Just let me know, and I'll try and answer the questions as we go along, because sometimes it's useful in the context of the actual slideshow. So a good old Coca-Cola, when man was landing on the moon, did the first commercial life cycle assessment, comparing bottles of glass versus bottles of plastic for their diabetogenic materials called Coke. And it was then that people started to realize, oh, okay, so it does actually matter. It's not just the fact that glass is better. Well, it depends. A lot of life cycle assessment is it depends. The problem with the glass bottle with Coke is it's heavy. So although glass has a relatively low carbon footprint per kilogram, it's heavy because you have to make it heavy because it's often breaking. And so that's actually the reason why a lot of movement went to production of plastic bottles for many materials, not just Coke or milk. That was the first one. So we've been around for 50 plus years. And we have a standard for this approach, which is the International Standard Organisation for Standards. And you can imagine the cycle involves all of these things, whether it be digging something out of the ground right through to either end of life or reducing, reusing and recycling. So this was pretty simple in a sense compared to the multi-centre randomised controlled trials that I'm involved with Intensive Care Society. It was single centre, observational, non-randomised, prospective, all those bad things in inverted commas. But really the only way you can do life cycles, because doing a prospective randomised controlled trial would be an absolute monster to do. And we just simply don't have the resources for it. Furthermore, you can get an idea from just a relatively small number of people where the hotspots are going to be, where the problems lie. From carbon, from water, from plastics, from petrochemical use, from landfill, from pollution and other forms of environmental factors. So the ethics was obtained. We went through a checklist as usual, and we used the standards that we've just mentioned. There's a goal and scope we've sort of mentioned. There's an inventory analysis, and we'll go through this, an impact assessment and interpretation. So the goal and scope, system boundary, what lies within the boundary and why. I'm not going to get you these answers to these, but it's basically that you're looking at all life cycle stages. That cartoon you saw before of the circle of starting from raw material extraction through to discard is all looked at in this study. As I mentioned, the system boundary is including all the things that are happening inside the operating room, including energy use. And we actually did an anesthesia-only study prior to this, where we actually looked at a similar number of patients having knee replacements, just the anesthesia. We'll go through that briefly. We excluded hospital and pharmaceuticals, and the primary outcome was carbon dioxide. So this is what we call system boundary. And you can see up the top here, you don't include the building of the hospital or the pharmaceutical infrastructure to make the medications, but you do include essentially everything else. So you can see the things that were included and those that were excluded fairly clearly. And so anyone can look at that and go, oh, yeah, it's a bit like looking at a consort diagram in a way, or patient factors that you'll, if you're looking at age and sex and all the rest of it, you'll be able to pick up quickly what was and what was not included. So we mentioned elective operations. We looked at all the things being used. We essentially were mainly interested in what was the composition, the place of manufacture, the mass, because that all quickly builds a story about what the carbon footprint is. And you can see a lot of different things here, all sorts of things that are being used by the surgeons, not like the palliative care physicians who would be using a lot less than all these things. And we can discuss your particular specialty down the track. A varying approach to single-use items. There was a little bit of variation, but not very much. The orthopods tended to use similar things. Apart from the metalware they were using, where you'll see there's quite a bit of variation according to how many toys they got to play with as they bashed and crashed their way through the knee replacement. So you can see draped sterile gowns, surgical trays, and a background paper that we used for this. So in the background, this is my PhD more than a year ago, we were looking at steam sterilizer energy use. And that was a very important form because it allows you to very quickly work out the footprint of steam sterilization is for all the reusable equipment. And you can start to, as you imagine, you've got a kilogram mass of things going in there because we've weighed the mass. And we know how many kilowatt hours is being used. And from that, you can work out a carbon footprint associated with that. Now, what I was getting to in that previous French study, or even the UK study by Rizan, the footprint of this is relatively small because you're using nuclear energy in France, or you're using mainly gas or wind to a large degree in the UK. So the carbon from anaesthetic drugs were estimated from a previous study, and it was an approximation. Part of the problem, as you would know with medications, is it's all hidden and no one knows what's going on apart from the company making it. And you're quite free to look at our study of morphine. You just look up, I suppose, McGain and morphine, and you'll find that on PubMed. That was just a study of one medication, an important medication. 50% of the world's morphine comes from Tasmania in Australia. But nonetheless, only one medication. That was a mammoth task to work that out with the company, with their engagement, GSK and Baxter for intravenous morphine. So really just trying to say that I freely admit that the drugs that we used here, sorry, it's my friendly dog, is relatively small. But there's a bit of unknown there. Just hang on a short moment, the team. Is everyone still following there, Kate?
Yep, we're all still with you, I think. Just looking at faces.
Yeah, sorry, I'm just.
Oh, I've got a hand up though. Oh, it disappeared.
Yeah, I'll answer in a moment.
That's all right. Oh, I think it was a thumbs up rather than a hand up to say we're all good. I assume he's dealing with the dog.
Yeah.
Yep.
Okay. Now I need to share again, don't I? Where are we? Where's the team gone? Usual. Can you still see that, Kate?
Yeah, it's just not on slideshow, but we can see the slide. Yeah, okay. That's it. Perfect.
Yeah, we'll go on to that. This is the tricky part that those wanting to engage in it may find difficult, and this is where I think the role of the Lancet Med Zero is going to be really important. It's this concept that there's a background inventory Echo Invent is a Swiss-based one. There's also Australian Life Cycle Inventory. There's also Open LCA. So there are some open sourced informations. There's also this Dutch group, Simapro from Prey Consultants. They produce, I suppose, the software behind this. The problem with the issue about this is you can. So some of you have probably already gone for the Centre for Sustainable Healthcare, Rachel Stancliffe's team, and looked at this and done a little, half-a-day course with them. That's really a really nice introduction. It gives you some nice approximations. It's tricky to use that because it lacks the detail allowing you to do that. If you're doing this sort of study that's going to be published. So I just put a call out to say some degree of caution. And one of the problems is that we don't have enough people like Scott, who I work with as the LCA's expert. There are far more palliative care physicians, let alone anaesthetists, than there are LCA experts in the world. So it's a relatively rare job. But needless to say is you can do some approximations because we're getting better. I'd also call out to the Canadians Healthcare LCA. You might be able to find some useful information in there. That gives some information and data about this sort of thing if you're doing similar sorts of studies. I mentioned this impact assessment using global warming potential characterization factors, it's called. And yeah, there was a certain amount of waste that was used, and of course that will depend on whether it's clinical infectious waste or if it's actually bleached, or if it's then landfilled, or if it's burnt in the case of the UK. So all those factors are important for coming up with a final footprint. There are a few other little things that are important. We did recycle to RAP, and then pharmaceuticals were incinerated. So all these things change the footprint of whatever you're trying to look at. So it's not just, and the Lancet Med Zero will provide this eventually, but it's certainly not going to happen overnight. Then, engineering was quite a bit of work behind the scenes, air exchanges, temperature in versus out, because then you can start to work out the flow or of warmth or coolth, as the engineers talk about it. And then from that, you can develop an energy use. We use then, because you only measure for a couple of weeks, you've got to use a model. Trinsys was one of them, based in the US, where you simulate what you believe would be the use, and then compare it to what the real use is for a few weeks, and then the model builds on that, and then you blow it out for the whole year according to the season, because as you imagine, if you're studying it during autumn, that will be very different to the heat and the heating and cooling that might occur in summer. And that will, of course, depend on your geography. The heating goals I mentioned there, okay, the number of things. So you can see there's quite a lot of detail. The reason why I'm showing you this is just the level of detail you want to go to if you're going to really go the whole hog, as it were. I can assure you that not all studies are done in this way, but I just want to show you, because to me, it is important to be open and to be honest about the detail you want to do. And to me, the methods are always critical in any sort of research, be it intensive care research or more broadly sustainability research. So hopefully people get a bit of an idea what I'm talking about there, about calibrating over the year from data that's only obtained, because we're not going to sit around and obtain data for a whole year, given that it was prospective. We mentioned the loads. Interestingly, all sorts of things were being examined there, including occupant number. You'd be surprised to know that we burn about 100 watts an hour. It's a background, just infrared production by existing and standing in the operating theatre, a bit less if you're lying down like the patient anaesthetised. But having 8 patients in the room really does increase the cooling requirements of an operating room, for example. Less of an issue in the UK than it is in Australia. Also importantly, 20 air changes an hour. So you can see most in your palliative care wards, it depends. It may be 2, as low as 2 air changes an hour, or probably more likely 6 air changes an hour for most standard hospital rooms. It's 20 in an operating room. So you can see that will increase. In other words, every 3 minutes, the entire volume of air is being moved out of the operating room and a new volume being moved in. So lots of energy being used. This was our original study. Then I won't bore you with the detail, but you can just get an idea of, you can see all the sort of things that we use. That this is just the anaesthesia, and you can see these are all the things that the anaesthetists were using. For a knee replacement, you can have a general anaesthetic or a spinal, and some anaesthetists actually did the combo of general and spinal, the spinal being for post-op analgesia mainly. And I won't bore you with it, but it's just to say you can see there's a long list of things. And there's a long, you can see mass of things being used, as well as kilowatt hours and those sorts of things, as well as even the gases you can see in that bottom left-hand corner: oxygen, sevoflurane, etc. Then you can see, I just wanted to show you, that story I was talking about, steam sterilizer use. You can see quite clearly where all this is coming from and the amount of energy that's being used, and therefore the amount of CO2. And you can see some emission factors here for different things. You can look at that and see, my goodness, what's going on with cotton. Cotton is a really big user of energy. Why? Mainly because of the nitrogen. It's a very hungry plant, or at least the way we use it is hungry. Use lots of nitrogen fertilizers, and you probably know that 1.5 to 2% of the world's carbon emissions come from nitrogen fertilizer production to feed our hungry 8 billion people. And so that's where that's coming into the story, as well as phosphates, as well as the cotton gin manufacturing, etc. So per kilogram, it's higher than copper, which is quite extraordinary to think about. So then you've got all these other things like, oxygen. This is obtained from echo and vent, or from other sources that you'll see available. So look, I'm not going to spend too much time on anaesthesia. It's needless to say that what it was a little surprising was that something like, why on earth would a spinal anaesthetic have a higher footprint than general anaesthetic? I mean, my goodness sake, Forbes, it's just a needle in the back. Well, it's not just a needle in the back, of course. It's the fact that you're still using all the same medications for for example, cefazolin, for antibiotic prophylaxis, whatever it happens to be. You're using more oxygen because we actually run higher flow rates. See, blue is oxygen, 6 to 10 litres a minute, rather than 1 or 2 litres a minute for general anaesthesia, so the blue is less. Sevoflurane in general anaesthetic is important. What do these numbers mean? When I was just saying, divide it by roughly 2 and you'll see the litres of petrol. So you talk about 9, set between 8 to 10 litres of petrol being burnt for the anaesthetic, for knee replacement, which takes, 2-3 hours. So it's not a huge amount, but, it's just the number of these operations being done that add up. And you can see, importantly, spinal anaesthesia, it's the actual fact that we use gowns for spinal anaesthesia, and because we're based on coal in Victoria and Australia, which is changing, which is good, but still a large component for the spinal anaesthetic. You don't use a gown for general anaesthesia because you're not doing a spinal. So all those sorts of things coming out of it, and really interesting sort of part of the story for anaesthesia. I'm going to quickly move on to this is the orthopedic operation. What I find really interesting is the variability of our orthopedic cousins. You can see a minimum of 32 kilograms of reusable metalware to a maximum of close to 50 kilograms. So, 1.8 times as much, mean of 42 kilograms. It's a lot of mass. It's a lot of toys. This is the same operation. It's all elective. There's no redos. It's not emergency. And yet you've got quite disparate variation. And that does matter because it changes the number of, the amount of steam sterilisation being done. And that matters particularly in a place like Australia where coal has been used. Less of an issue perhaps in France. Of course, by using less, you'd actually have saved money as well. But as your energy use changes, that will change, of course, the amount of carbon being produced. And you can see, similarly, you can see all sorts of things being used for here. I'm not going to dwell on that. I'm going to give you graphically in a moment. And I'll perhaps go through, I'm going to miss this because of the interest of time. What I want to go through is the next one, okay, because I think this will give a bit of idea, okay. So this one here, once again, we're looking at anaesthesia. So this is just that anaesthetic use part of it you saw. So this is the naughty anaesthetists who are not really that naughty anymore. It's all the naughty orthopedic surgeons who are causing the chaos here. What is interesting is that, at least in Australia, it's this, you can see the prosthesis. Sorry, I'll just come back to that. So the prosthesis alone Of course, you're not going to get rid of the prosthesis, but because it's made of components of titanium, vanadium, chromium, as well as steel, that is a similar footprint to the entire 2 to 3 hour anaesthetic. Nevertheless, prosthesis will last for hopefully it's 15, 20 years, but it does require a lot of energy to make it because it's rare metals. You can see the heating, ventilation, air conditioning, relatively small, interesting, and we can just touch on that in a moment. Big use, of course, was the orthopedic surgical set. This is the reusable stuff. Over here, you've got polypropylene, that blue wrap that we use, and you can see all these other sorts of things, latex and cement and saline bags and so on and so forth. No, not 1 ton, Kate, 132 kilograms in total.
Good.
But that's okay. That's all right. Yeah, we can do 7 of them perhaps. That's about the distance between Melbourne to Sydney. I don't know how far London to Edinburgh is. How far is London to Edinburgh? About that sort of range? I don't know. Anyone know? Yeah, you can do a little Google search of that. But it's a fair way. I think you get London, you get a fair way north up to, probably beyond York, I suspect. And that's an average for a knee replacement. Most of that's coming from orthopedic surgery, which is sort of understandable. Most of it's from, at least in Australia, stem sterilisation. About 26% in total is coming from this is the total, not the 80%, single-use devices, as in wraps and things like that, and about 10% from anaesthesia. About 10% from engineering. What we're missing there is the engineering that's happening when the operation isn't happening. So in other words, out of hours, or the fact that in Australia and still in the UK and many other countries, we leave these jolly operating rooms on. Operating rooms are interesting because they actually have their own heating, ventilation, air conditioning separate to the rest of the hospital in general, and that with a positive pressure. And that uses a lot of energy, and it's somewhat ludicrous that we leave it on all the time when most operating theatres are never running on weekends and never open at night. Some are, but you can stratify, of course, that. So a lot of opportunity there. Reusable equipment, we mentioned substituting, just reducing the amount of stuff that's being used, being more frugal as an orthopedic surgeon, particularly matters if you're using high carbon emissions. Coal, for example. These other factors, renewables make reusable better, which, as I've already mentioned, as you move toward that. And parts of Australia really are getting there. It's quite exciting to see a state like South Australia, for example, being 80% renewable electricity, wind and solar now. And we in Victoria are moving very rapidly. Essentially, during the day, if you're in a hospital that's public, it will be run on solar or wind, which is a new thing, happened over the last year or so. Single-use equipment, yes, that's really big. So we're talking about 9 kilograms. This one operation for a knee replacement. There's a lot of single-use still being used. The orthopedic surgeons like their single-use drapes. So it's different to our ENT or general surgeons or plastic surgeons who are very happy using reusable. And look, we can talk about the infection prevention story there as well. What we're moving towards is actually getting rid of that blue wrap altogether and using a reused, so actually a washed and re-sterilised, saves money, a polyethylene wrap, so a completely different type of wrap that is actually reused. And I mentioned that reusing reusable energy will about halve the CO2 emissions. Only by making the wraps reusable, though, can one significantly lower the CO2 emissions, which we're moving towards. Just going to go mention the prosthesis. That's a bit more difficult to change. I've already mentioned anaesthesia. It's sort of the law of diminishing returns. Yes, there are things we can do. We can use less oxygen. For most of the time, you don't actually need 6 to 10 litres of oxygen for an average spinal patient. You could run 1 or 2 litres. We're not using nitrous oxide very much anymore, nor desflurane. So I think those low-hanging fruit have gone. But as I've mentioned, HVAC is important as well. I mentioned the setbacks. These are all things that we're moving towards. So it is exciting being involved in research projects that are setting back operating theatres, looking at steam sterilisation, efficiency gains. How do we actually stack sterilisers better and safely? All simple sort of stuff, but all quality improvement, health services research stuff. So a lot of things are coming from this research, which I'm very excited about. So I'm just going to come out of that there because I don't think there's too much more. So I'm just going to come to the end there. Yeah, you can sort of see what I'm talking about there. I'll just finish up with this slide. That, the reality is China, which produces about a third of the world's carbon emissions now, has a CO2 emissions profile similar to Australia, a lot of coal, but Australia is changing even more rapidly than China is. We're now getting close to the global, we're just actually at the global average. I've been checking that that's 2022. We're at the global average. We're getting close to 40% now. Still got a way to go, but it is exciting to see what we're doing. And we hope that others can make this transition quickly. So rapid transition to renewables, steam sterilizer change, single use should be replaced, reusable wherever possible, and reducing the unnecessary equipment being used. Don't know what happened there, lost that. That one went a little bit off awry, but I shall exit that and answer any questions because we've got about 15 minutes.
Brilliant, thank you so much. I have a few thoughts and questions, but I'll just see if anyone else wants to speak first. No hands up yet, so I'm going to start. I suppose my first sort of thought is, how do you identify your first target for change? So you do all that amazing work, and then how do you kind of go back to your surgeons, present the information, get the engagement, and then decide what you might do differently?
Yeah, I mean, that's always an interesting point. It's like there are a number of complex problems, complicated and then clear problems, as some others wiser than me have tried to divide problems into. There's some fairly clear problems here that can be solved relatively easily if you have the infrastructure. Of course, that does depend on the infrastructure. So I've mentioned like the wrap, the reusable wrap that we're using for reusable equipment. So not only do you have reusable gowns, but you have reusable wrap. So that's what we're moving towards throughout Western Health. And that requires obviously a company that will engage with you, that will allow you to do that, but they're happy, like a linen service provider, in other words. So we are able to do that because our linen service provider says, yeah, let's experiment. Let's just do this. We're one of the very few places in Australia that does that. Other hospitals are not able to do that because they don't have a linen service provider who will allow them to do that because they just don't do it, or they have no desire to do it. And because the competition perhaps isn't as intense as it should be, I'd say, or that they're not really listening to the consumer, which is in this case the staff. So I just say that was a relatively easy thing to do, but would be simply impossible to do if you do not have a sim. So that's where you need to petition. You can see there's a whole series of other problems you have to work through, right up to the level of the CEO, to say, no, we want to have reusable linens, or we want reusable wraps around our reusable linens, so on and so forth. So some of my colleagues were simply unable to do this despite their desire to do it. And that is an interesting story about where power lies as well. You would think that surgeons would have a bit of power. I've always thought they've got power, but it's not always the case.
So it's that engaging with
toys.
Yeah.
So anyway, this is just a little example of one. I don't necessarily say that's the most important, but it's very visible. Like, that's the thing about linens. They're very visible because you can either be dressed in oil, the polypropylene disposable chuck away after one use, which is what most of Australia's like, or you can move to still oil like a polyester base, but it's going to be used 100 times. It's going to be washed 100 times. So you're reducing the plastic production by 100-fold, thereabouts. That all requires that process of working with it. What I would say is also important, what we're working on is working with the engineers now to set back operating rooms out of hours, but that's a mammoth task as well, because it involves infection prevention, all sorts of concerns, measuring fungal spore counts, those sorts of things, to make sure we're not increasing that at the end of an operation or at the beginning of a morning operation, because it'll be set back overnight. How far can you set back? Those sorts of things. I think then there's the I think with the orthopedic surgeons, for example, it's like, okay, well, here's what is happening for the outliers, for the people who are using 50 kilograms for their knee replacement. So here's for the people using at 30, and just showing them what we need. What we don't have at the moment is a feedback mechanism that says, oh, by the way, did you know that you're using 10 kilograms more than everyone else? You know, whatever it happens to be, a little that is very powerful in the world of antibiotic stewardship. Oh, did you know that you're using meropenem 5 times more often than everyone else in your cohort? You know, those sorts of stories are very, very powerful feedback loops. We haven't got there yet. That's something I really want to explore. We are going to explore as part of our other studies about reducing the amount of oral, so increasing the amount of oral medications versus IV medications on the wards, but that's another story beyond orthopedic surgery. So I mentioned that story about metalware use, Kate, because it's actually it's something an individual can change. So there's micro, meso, and macro changes. Micro changes: I stop using desflurane, stop using nitrous oxide. I use 1/5 as many syringes as anyone else does. You know, I'm just giving examples of sort of things where they may not be true, but you know that's what a micro person can do. You can also influence, you know, the anaesthetic nurse or the other scrub nurses to, you know, use less. That sort of thing can happen. But then you move into the meso, and meso is much harder. I've already mentioned, like a meso level change would be, as I've mentioned, all of those things that involve other aspects of humanity, working with a linen service provider, working with the orthopedic surgeons, obtaining feedback, talking to the pharmacists about using less, you know, medications in certain operations, whatever it happens to be. That's all meso level because it all involves other humans, which all requires, you know, an examination, I suppose, of translational medicine, you know, combi, if you know the, you know, capability, opportunity, motivation, behavior changes. And then there's the macro level stuff, which is more about, you know, college and safe, nice, and those sorts of groups that can potentially change the overarching theme and the agency. So, I mean, I don't know, but wouldn't it be exciting if NICE just said, well, that thou shalt use reusable equipment, if at all possible? You know, that would be a really profound statement. People go, oh, okay. So, you know, like my engagement with that, I suppose, is getting on with the Australian Commission for Safety and Quality in Healthcare actually having a sustainability module, and so then that signals, because that's an accrediting body for all hospitals and general practices, we can start to say, well, oh my, this is important. It sends a signal. However, Kate, I think what we're seeing is there's a lot of really good work on the part of colleges and societies throughout medicine and nursing and the rest of it, and there's a lot of micro level stuff going on. There's not much meso level going on really, because it's much harder. It's really hard to make those changes within your hospital, and people give up, you know, because they find, oh well, there is no living company I can do this, or I can't use reusable masks. You know, I can't do this alone. Throw their hands in the air and give up. It's hard work. Let's not make it up. So there's something in the chat.
There was something in the chat which someone I was going to call on, so I'm glad she's put a question in. So one of the things we've tried to do with our award is to encourage our teams to engage with those other parts of the organisation. So we have a section on supply and procurement, because as you've highlighted, if you don't know who your supplier is and what they might be able to change and where the power lies, it's difficult to influence that. Polly, I see your question. I was actually going to ask if you would be willing to speak about the project you did with reducing syringe use around subcut injections briefly.
Maybe you misheard me. It wasn't so much subcut injections. No, it wasn't. Is that what you?
Oh, that wasn't you. Sorry.
I'm looking blank.
That's all right. Is the team who did that project here? Otherwise, I'll just briefly mention it. I always get confused. Sorry, it might have been someone else. So that one of our pilot sites did a brilliant project where they identified a difference in equipment use when going to give a subcut injection, which is something that we do all the time in our field, and then very straightforwardly put together a poster that showed how much equipment some people were using, how much equipment you could do it with, and it was acceptable to do it with, and then kind of rolled that out and just got a 50% reduction in single-use plastic. Brilliant, straightforward, identified, and I was struck, Forbes, by what you were saying. I've switched to first names there. There we go. By seeing that difference in practice, and that was something that they'd identified. So I just mention that as one of the projects that we've had going on.
Mm.
But Polly, sorry, your question was, how are other centres getting on with achieving their life cycle assessments for the Bronze Award? So I can talk about that, but I wonder if any other site wants to talk about that. I think that's a no. So I'll answer, Polly. Do you want to talk about how you're getting on, actually?
With the whole award very well, but this is like our final piece of work that I think has been almost left to the end because we've slightly avoided it, thinking it's really complicated. Hearing that we just need to kind of look at the basic principles, that's really helpful. But even within that, we're just thinking how much we need to really go into. We're looking at doing it around a toothbrush or something that we use for mouth care probably. So it's just how much we need to gather and
yeah. So if people don't mind, I will just share with you briefly what some of the other sites have done. So what we've asked people to do is, and that's why we've reworded the question, just to, and I see Christine said fit a bit too big to find all the data. So we've asked you to look at what the principles are. So as Dr. McGain was explaining, that idea about what's your goal and what your scope, what are you including, looking at production, looking at transportation, looking at use, and then looking at disposal as well, but not necessarily having to do a project like has just been described, but seeing what data you can find. And I am going to say that AI is quite a useful tool here. It will give you some of the information which you can then obviously fact check, but will give you a structure. So it's to get you as a team to start to understand. It's not just sort of the use and disposal of the bit of kit in front of you. It's how did it get to you in the first place? Where was it manufactured? How far did it come? So it's starting to get you to think about those, the bigger impact around that product.
I think it's interesting, like intensive care, the opportunities for individual, converting to reusable products, for example, from disposal, which is very much a theme of the operating theatre. Intensive care is much more about patient care that is appropriate. I think it's actually much more important to be always considering, is this the best care for this particular patient, or can we be more conservative in our approach? And I think that that gets into tricky ground about not avoiding good patient care, but at the same time, end of life care is just incredible. We're not doing it because of the environmental footprint. We're doing it actually because in the end it's what we would consider the best for the patient, not to appear too patriarchal or paternal. But these are real things. This is going to be increasingly an issue as we struggle to cope with an aging and increasing population with a healthcare budget that's being stretched. And so I do think that these things should be considered, but not the primary motivating feature. So, in other words, if you have a patient in the intensive care unit every day just sitting in the intensive care unit on a ventilator, will be, depends on where you are, but 150 kilograms of CO2, that sort of range. The actual interesting part about it isn't so much the ventilator or things like that. They use relatively small amounts of energy or stuff. It's more just the fact of being there and the energy use that's being required to look after the patient. By that I mean heating, ventilation, air conditioning, as well as the amount of disposable equipment that's being used. Just thoughts, I think, and I think that's particularly relevant to palliative care. And you might have seen there's been some discussion of this. You could just look up Christina Ritchie, Ritchie. Might just put something in the Lancet Palliative Health a year or so ago. There's been other work, and I think there'll be ongoing work in this field of palliative care, which is interesting. Yeah, thanks.
I'll just speak to a couple of the comments in the chat. Kay, yeah, I completely agree. And you saw me hesitate before I said I've used AI to do life cycle analysis. Of course, there's a bigger environmental footprint, and I tend to think is this question going to take me more than 10 Google searches to answer? Because it's the statistic I hear repeatedly reported is it's 10 times more energy use than a standard internet search. And if I think it's going to save me more than that, then I might use it. But yes, compromises all over the place. Yeah, struggling to get responses from manufacturing companies is definitely an issue. And I heard Forbes reference that as well, you know, struggling to get information out of drug companies. If you've tried in terms of the award and you can't, that's okay. Just giving there's a database in the UK where you can get government figures for equipment use, which I can point you out if you haven't found that yet. So you can get a generic factor for a carbon footprint if you can't get the specific one.
And I'm just mentioning the I mean, certainly you could look at sorry, it's Christine. There is some information out there in the web you could find for if you just go to PubMed, and you'd be able to find there is some information about ambulance transfers and things, and there certainly is intensive care. There's a few studies, ours being one. So you would be able to find something there that would help you. Hopefully, Christine, that will help. From Birmingham.
Yeah. But yeah, just remembering one of the reasons we did this session is because you were all struggling with this, and it's getting you to understand the basic principles and how you might do a life cycle assessment rather than having to produce a publication ready study like we've talked about today. But it's getting to be familiar with that process. I'm sure you all have 9 o'clock handovers to go to, or other meetings to go to. Are there any last thoughts or comments other than a big thank you? All right, Polly, yes, I see that. I will send it to you.
Well, thank you very much, Kate. Thanks, everyone.
Thank you for joining us. That was really interesting, and lots of thoughts.
Good on you.
All right.
Thanks for all the good work you do.
Thank you.
All right, I can hang on for a minute, so if there's any last questions, give me a shout. Lovely. Hi, Mahayman. Long time no see.
It is indeed, which is why I stayed on till the very end just to say hello. It's nice to see you again. I'll let you get on with whatever you're doing this morning.
All right, it's lovely to see you. Bernie, you're still with us? I would just stop recording. Hang on. I always forget to do that.